Welcome. Thank you for joining us today. My name is Jasmine Victor. I'm the Director of Education at Alzheimer's Orange County. Today we have Dr. Kent Peppard presenting normal age-related cognitive decline, mild cognitive impairment, and dementia. Thank you.
Okay. I'm a clinical psychologist, and I specialize in the neuropsychological assessment of neurocognitive disorders or cognitive disorders. And today I'm going to talk about the difference between normal age-related cognitive decline, mild cognitive impairment, and dementia. I think this is a very important topic for anyone entering this field, and particularly for family members to understand what these terms mean and how they're differentiated from each other. Now, the neurocognitive disorders are categorized into three basic categories. Delirium, mild cognitive impairment, and dementia. I have to mention delirium because it is a cognitive disorder that does come up from time to time, and families need to know about this, clinicians need to know about this. Mild cognitive impairment is not in the new Diagnostic and Statistical Manual of the American Psychiatric Association, the DSM-5. It's described as mild neurocognitive disorder, so there's no mention of MCI or mild cognitive impairment. And there are multiple subtypes. I'm going to get into that in just a moment. Dementia is not in the DSM-5 either. The term used is major neurocognitive disorder, and there are multiple causes and types, which I will be getting into as well. So this is a very important slide. This is something I think about a lot when I'm doing my evaluations. Are there symptoms that the person is presenting in the neuropsychological assessment, and which are observed by family members and even the person themselves? Is this normal aging? Is it actually evidence of a cognitive disorder such as mild cognitive impairment or dementia? Now, someone doesn't move from normal aging into dementia overnight. There are rare cases where that would happen, such as with a major stroke, a brain tumor, a traumatic brain injury, a severe brain infection, something like that. That's quite rare. Most people that develop dementia, and the most common cause for dementia is Alzheimer's disease, they pass through mild cognitive impairment on the way to dementia. And there's a transition from normal aging into MCI. And there's a new category for that line that's between normal aging and MCI. It's called subjective cognitive decline. And that's something that's appearing in the literature. And I do see people with that from time to time. They believe that their memories are definitely changed and definitely worse, but it doesn't show up on neuropsychological testing. It could be a precursor, and if I see them a year later, now they're in the MCI range a lot of times, because now they're scoring in the impaired range on the neuropsych tests. Now, people can stay in the MCI range for a number of years, 5 to 7 years, depending on if there are other factors that are contributing to a decline in their cognitive functioning. I'm going to talk about that in just a moment, but it's important to think about MCI as a condition. It's a diagnosis, but it's also a condition. There's over 70 different causes for MCI. There's over 70 different causes for dementia. They happen to be exactly the same 70 causes. And so, also, someone does not go from MCI directly into dementia. There's a transition, a slow transition. And I see this quite often. This is because as the person is losing cognitive abilities, their unable to perform some or all of the complex activities of daily living: driving, paying bills, shopping, setting up and getting to doctor's appointments, things like that. So I am going to go into more detail with that in a moment. So I hope that this is clear. Well, let's talk about what's normal as we age. Our short-term memory gets weaker. This is because the brain shrinks as we get older. And actually, your short-term memory gets weaker in your late 30s. That's because the hippocampus shrinks. And when I score my tests, I have to use normative data that is age adjusted. That's the only fair way to do that. If I was seeing someone that's 75 and using normative data from a collection of 25-year-olds, it would not be fair. Our memories are best in our 20s and 30s. And that's a good thing, because that's when we're in school, we're learning our trade, our skill, whatever, our careers. So short-term memory gets worse as we get older. It's not significant, though, and we find ways to compensate as we go along. We write things down. We use appointment books, checklists. We keep things in the same place. So it's not a big deal. And you can still learn new things. It just takes a little more effort. Our attention span also gets weaker as we get older. It's a normal, natural thing, probably because the frontal lobe shrinks. And some people who had attention deficit disorder, this can become worse. I've actually seen people who tell me they did not have attention deficit disorder, but they do now. So that's an interesting thing. You just have to adapt and adjust and not multitask. I'm going to talk about what that's all about in a moment. But attention span is critical to memory. And that's an important takeaway from this presentation. If you don't focus on something long enough, it doesn't get into the memory system. This is why kids with ADD don't do well in school in subjects they're not interested in, because they can't pay enough attention, but they can come home and play video games for 3 hours and tell you the world record scores for the 10 most popular games. I remember this comedian said, "My wife says I never listen to her. I think that's what she said." So that illustrates the point. If you try to do too many things, you're dividing your attention span. And when you do that, you can miss details, you can make mistakes. For example, if I'm paying bills and my wife comes up to me and starts talking to me, I have to say, "I can't talk right now. I could make a mistake." And that's what people need to do after 50. Okay, the next thing that changes as we get older is our speed of information processing. This is why seniors drive slower. What they're doing is giving themselves more reaction time. It's a normal, natural, actually an intelligent approach to things. But that's because the frontal lobe shrinks. You just cannot process the information as quickly. This is why you don't see old quarterbacks and old fighter pilots, old race car drivers. They just can't manage the information quickly enough. And in my battery of tests, I examine this, and if someone is really slow, I express a concern about their driving in my report. I don't contact the DMV, but I do give an opinion on that. Okay, the next category is multitasking. Okay, there's no such thing as true multitasking. It's simply shifting from one area of focus to another, from one thing to another. When you're young, you can shift away and you remember what you were doing. So it feels like you're doing two things at once. The brain can really only focus on one thing at a time. Now, walking and chewing gum is not multitasking, because neither one of them require your absolute attention. But talking on your phone while you're taking medication, that's risky. And after 50, I don't think people should do that. Because you'll pick up a bottle while you're engaged in the conversation. You'll think, did I just take this? Or if you're focused on the medication, you get back on the conversation, you say, now what were we talking about? Do you see, you have to be reoriented. And so it's best if your medication regimen is very complicated, my advice is focus just on your medication while you're doing that. Also, our vocabulary actually can increase. This is interesting in terms of it's the only cognitive domain that can get stronger as you get older. In my battery of tests, I examine 9 different cognitive domains or abilities: memory, language, visual spatial, speed of information processing. And language, actually, our language skills and vocabulary can increase because our culture is changing, technology is changing, new words are being added to our vocabulary all the time. Plus we use language all the time. And so that skill is always being reinforced and strengthened. So that's a good thing. So if someone is having very noticeable word-finding difficulty, it's something that needs to be checked out. This is what happened with Bruce Willis. Those were the first symptoms. He was having a lot of word-finding difficulty. Okay, what does not change if we're normal? And that's important to know. Our immediate recall, if I was to give you a 7-digit number, you should be able to give that back to me. If you can't do it, it doesn't mean you have dementia. It could be that you're just preoccupied with something else. Our verbal intellect, like I just described, does not change as we get older if we're normal. Long-term memory also is intact, even in people who develop Alzheimer's dementia. The long-term memory are the last memories to go. They can still remember old information. The ability to learn new information is something we should really take advantage of, because retirement is considered a risk factor for developing dementia. All those connections, all those synaptic connections that we grew through our education and our career, when you stop working, your brain is not being challenged the same way. So those connections can wither away because they're not being reinforced. So it's very important that you keep learning new things and stay socially active as much as you can, but learn new things like a new language or a musical instrument. People should keep learning, because if they stop and they watch TV all the time, they can start declining. Our intelligence also does not decline if we're normal, and actually your intelligence is enhanced by life experience, and that's wisdom. We acquire wisdom. Okay, now these are common causes for normal forgetfulness, and some people think they have a serious problem when some of these factors are contributing to their cognitive functioning. For example, not paying enough attention to something. You're trying to do too many things at once. Having significant distractions. Maybe you're worried about your grandchild who's struggling in school or has a problem with drugs or something, and you're worried all the time about someone. Or your own health issues. Stress can certainly impact memory because it affects your attention span and concentration. Anxiety, same thing. If you're anxious about things, it's harder to concentrate. Fatigue interferes with attention span and concentration, and as I said before, anything that interferes with attention and concentration will impact your memory. Sleep deprivation is another thing that can cause people to have memory problems. And if they have sleep apnea, that's a serious problem, because what's happening is they're not breathing perhaps hundreds of times during the night, and they're depriving certain parts of their brain of oxygen, which means they're killing neurons. and you don't want to be killing neurons, particularly in areas that have to do with memory, like the hippocampus. Low blood sugar is another thing that could cause people to lose focus. Being dehydrated. Now, there are some people that they're dehydrated, but they're not thirsty. And I've noticed this in a number of older adults. They go all day long and they don't drink any water. And that can definitely impact your cognitive functioning. Normal grief. The longer we live, we're going to lose people, we're going to lose things that we cherish, and we're going to grieve losses. And that can interfere with your cognitive functioning. Certainly clinical depression can affect cognitive functioning. And there is a type of dementia, it's rare, I've only seen a few cases myself. It's called pseudo-dementia, wherein depression is the cause of the symptoms of depression. And the way you know that is they treat the depression, and then they repeat the neuropsych testing, and the person scores in the normal range. There are certain medications that can definitely affect your cognitive functioning. For example, there's a medication called gabapentin or Neurontin. If I take that medication, I would score in the MCI range. I have a twin brother. He takes it. It doesn't affect him at all. So you can see that some people are more vulnerable to that. Also, I'm a cancer survivor, and I was on chemotherapy for 11 months, and I had chemo brain. So if I had taken neuropsych testing, I would have scored in the MCI range. Fortunately, that cleared up after 2 years. So you see there's things that can happen. I recently evaluated a man who he now is scoring in the dementia range, but he was perfectly normal before he had a quadruple bypass surgery. Now, when that happened, he suffered oxygen deprivation to certain parts of his brain. And now he has severe memory impairment. He can't work. He has executive dysfunction because his frontal lobe was damaged. So he's really a completely different person, according to his wife. And the guy's only 63 years old. It's really a sad situation. Okay, now what are some signs that someone has possibly a cognitive disorder and further evaluation is needed? If there's a noticeable change in thinking, memory, language, judgment, problem solving, perhaps someone has just gotten scammed, or they almost got scammed. And that's exactly what happened to someone I saw recently. This person was about to give away $50,000 to someone over the phone, but this man's daughter was listening to the conversation and could tell that it was a scam. Now, this man was very meticulous in everything he did throughout his life, but he was very vulnerable. So that's sometimes the first indication that there's a problem. The ability to discern something, to be suspicious, that's a frontal lobe task. And when the frontal lobe gets damaged, people can have some interesting problems. So if a change has occurred that is definite and persistent, that's meaningful. And I always ask that of the person I'm evaluating and the family members. Do you feel like this change is definite? Yes. Is it persistent? Yes. Is it gradually getting worse? Yes. That's very meaningful to me. Okay? It could be mild, but there's something going on here. And then, of course, if the neuropsych tests show that the person is actually impaired in memory or language, then there's objective evidence to support that the person has MCI or early dementia. Family members are an excellent source of information, and I practically will not do an evaluation unless I can talk to family members. Because if their observations match the test results, then it validates my assessment and it validates their observations. Now, we need to talk about delirium because with older adults, particularly older adults who have a cognitive disorder, they may develop episodes of delirium. And delirium is actually the most common psychiatric disorder. People don't even realize that. The reason is because of the causes of delirium. Now, delirium is an acute confusional state. It's characterized by disorientation and poor awareness or focus. There's a sudden onset, and it doesn't last that long, typically, if the cause is addressed and corrected. There's over 100 different causes for delirium. But during delirium, the person is not oriented to where they are, if it's severe enough. They may have psychotic features, such as hallucinations or delusional thoughts, and there may be agitation. Excuse me. During a state of delirium, memory is usually quite impaired. So people actually forget what happened during that period of time. Now there's over 100 different causes for delirium. I evaluated a young man who had a traumatic brain injury, and according to the paramedics, he never lost consciousness as far as they could tell. And he was in the ambulance just talking up a storm. He has no memory of being in an ambulance. He doesn't remember anything about the accident, and that's very typical. Now, the difference between delirium and dementia, and this is important, it's unfortunate they both start with DE, because it's easy to get these confused, because delirium can look like dementia, and I've seen it misdiagnosed. Now, delirium is a temporary condition. It's an acute, usually temporary, it's a physiological disruption of the normal function of the brain and the nervous system. So something is acting on the brain, okay? Now, dementia is different. Dementia is usually chronic, it's usually progressively getting worse, and it's caused by structural change, which means the death and loss of neurons or brain cells, with the accompanying loss of cognitive functioning and ability. If you lose enough neurons in your hippocampus, you're going to have memory problems. Whatever the cause is. It could be sleep apnea. It could be a tumor. It could be Alzheimer's disease that's attacking that. So that's a good way to look at this. One's temporary, and once whatever it is that's acting on the brain is removed, then the delirium goes away. Now, the most common cause for delirium is alcohol intoxication. And that's a really good way to look at delirium. It's temporary, right? It's a sudden onset. You keep drinking and you'll get intoxicated. When you stop drinking, it clears up. And there are degrees of delirium. It can be mild, moderate, or severe. But if you look at this list, there's many different possible causes here. Many medical conditions that can cause this. Fever, and if you look down the list, UTIs, a urinary tract infection, is a common cause for delirium in older women who have dementia. And I see this from time to time, and I know people in facilities, that's one of the things they check out. And you don't have to take the person to the ER, you just call the primary care physician, and usually they have the person come in and do a urinalysis to check to see what's causing that. But severe sleep deprivation can cause delirium, severe dehydration. So this is something that's a checklist that's gone through by ER doctors. They look at what were the circumstances. Now this is, delirium is commonly seen in the hospital setting for a variety of reasons. It's almost like a perfect storm for delirium for someone who already has dementia, because it's a new setting, it's stressful, they're there for a reason, they fell, they hit their head, they broke their hip, something's going on, right? And maybe they're giving you a new medication. Maybe it's a pain medication. Maybe it's a benzodiazepine to calm them down. All these things can increase the risk of the person developing delirium. Now, sundowning is commonly known in all the circles where people are familiar with dementia. It's a delirium syndrome of confusion and agitation occurring usually in the late afternoon or evening. And I've done a lot of reading about this and attending lectures. This is of great interest to me. What are the factors that cause this? And it's believed to be multiple factors, with something like fatigue being usually there all the time. But the person could be dehydrated, they could, maybe they haven't eaten in a long time, maybe they're stressed, maybe they're focused on something, obsessing about something. Or if they're living in a board and care and everybody in the house went to a day program, but they didn't. And now it's 4 o'clock and everybody's coming back into the house. Now this person is being overstimulated. So there's too much stimulation. And that can cause them to slip into delirium and start showing the symptoms of agitation and disorientation, sundowning. But once again, it's a temporary thing, right? They go to sleep, next morning it's gone. That's a good way to look at this. Now this is just a chart showing the differences, and I'm not going to go through everything here, but delirium can fluctuate throughout the day, and it's, like I said, temporary. It can last for hours or at the most weeks usually. But with dementia, it's very insidious. Beginning, the signs and symptoms are so mild, you hardly notice it. But looking back, you think, that was kind of a strange thing. And that really marked the beginning. And family members tell me this all the time, when they start to think back. So it gradually gets worse. Dementia gradually gets worse. There are types of dementia where it's not progressive, like you have a major stroke or a head injury. People don't think about a 25-year-old young man who had a traumatic brain injury who has dementia. Well, that is dementia. It's not progressive because the accident's over. But he does have dementia, and he's not able to work. He's not able to live independently. Okay, so this is an actual case of a woman who had hip surgery. I was working on the rehab unit, and she was in a lot of pain, so they gave her pain medication when she was transferred over. Well, she slipped right into delirium. She was very confused. She didn't know why she was there, where she was, and she was hallucinating, seeing cats and monkeys in a room. And the referral question to me was, does this woman have dementia, does she have delirium, or does she have both? Now, someone can have delirium all by itself, someone can have dementia all by itself, or someone can have dementia with delirium superimposed on top of that. So that was the referral question. So how do you figure that out? It's really not difficult. What I always did was I would go in on Sundays, and that was good because I wasn't interfering with therapies, but I also got to talk to family members, and that's exactly what I needed to do. I needed to talk to this woman's family to see how she was functioning prior to her hip surgery. And sure enough, she was 74 years old, fully functioning, independent. She lived on her own. She traveled across the country to visit her daughter. She paid her bills. She didn't need any help from anybody. And as far as the family could see, she didn't have any memory problems. So she didn't even have MCI. So that helped. And so my opinion was, well, as soon as the medication, the pain medication is reduced, she's most likely will return to normal. And that's exactly what happened a week later. So it's not rocket science to figure this out. It's just look at this logically. So now this lady, this was an actual case of family that I've known for a long time. A 79-year-old woman. She has dementia. Every now and then she gets very confused, disoriented, agitated, and she lives with her daughter, and her daughter has seen this a number of times before. So the first thing she does, she sets an appointment with the primary care physician, has a urinalysis done, and in virtually every case she has a UTI. So they treat that, and then she returns to her baseline, which is dementia. Now, it's important to know that delirium is hard on the body and it's hard on the brain. So too many episodes of this can take its toll. Okay, so let's talk about mild cognitive impairment. As I said, this is a condition, and it's characterized by mild to moderate deficits on neuropsych testing, but the person does not have significant functional impairment, which means for the most part they can live independently. They may be struggling with things, but it's interesting that the people that I see who have MCI, they all seem to describe their situations in a very similar way. I know I have a memory problem. It's frustrating. I'm concerned about it. My mother had dementia, so I'm afraid this might be the beginning for me. I have to check myself. It takes me 5 times longer to do anything, but I'm still able to live independently and perform all of the complex activities of daily living, such as paying my bills, go shopping. I can set up and get to doctor's appointments on my own. I'm still driving without getting lost as long as I drive in familiar areas. And now on the test, they score in the impaired range on memory, maybe language, maybe executive functioning, but it's not severe, and obviously the deficits are not severe enough to impact their everyday functioning, and that's mild cognitive impairment. Now some people are transitioning, so what that looks like is, let's say a woman who's got MCI and it's gradually getting worse. Well, she's started to forget to pay bills, so she's handed that over to her spouse. Or she's driving and she's starting to get lost, so she's handed that over to her husband. So gradually there's a handing over of the complex activities of daily living. That's what I ask about. That's what I want to know. The complex or instrumental activities of daily living are the things that are impacted first by MCI and dementia. The basic ADLs, dressing, grooming, bathing, toileting, feeding themselves, those are what are called the basic ADLs, and they are not impacted until much later in the course of dementia. So I never see those in my office. Now, what might family members notice in someone who's retired and living in the same house for 40 years? How could you tell if they have memory problems? Well, it's short-term memory. It's not long-term, because they can tell you a great deal about their early childhood and things like that. They can still do that. But it's the short-term memory. New information is not sticking. So what family members notice is that the person is starting to ask the same questions repeatedly, or telling the same stories, or forgetting recent conversations, or frequently misplacing belongings, not remembering the names of familiar people, forgetting that something is cooking on the stove. I had one gentleman, he left things cooking on the stove, and on 3 occasions the fire department was called, this is in Laguna Woods, because the smoke detectors went off. That's the first indication that he had a problem. Forgetting to pay bills or paying bills more than once. Forgetting appointments or to take medications. Whenever I set up all the appointments with the patients I see, because I want to talk to the person, I want them to get to know me a little bit, and I have some questions. But it's of particular interest to me who is setting this appointment up. Is it the son or daughter? Is it the spouse? And I sometimes ask, do you think your mom could have set this appointment up herself? And if the daughter says, oh, no way. Well, I've learned something right there. She's having difficulty with complex activities. The person stops doing things they once enjoyed, like reading novels or playing bridge, because that requires memory. Another early indicator is that if someone gets a new TV and they cannot learn how to use the remote, or they get a new cell phone and they can't remember the steps needed to operate that. So the difference between dementia and mild cognitive impairment, people with dementia have functional impairment. They can no longer live independently. They can't travel alone across country. They can't set up and get to doctor's appointments. Oftentimes they've stopped driving because they were getting lost. But there's significant functional impairment. With mild cognitive impairment, there's no significant functional impairment. There might be some difficulties with complex activities of daily living, but at this point, they're still able to live independently, for the most part. Okay, so these are the complex activities of daily living that I always ask about. Driving, shopping, paying and managing finances, preparing adequate meals. If someone develops early dementia, they stop cooking usually because they can't prepare a more complicated meal requiring multiple steps, or they can't manage their medication effectively, or operating appliances, or how to use a computer. They can't travel alone. Like I said, they can't set up and get to doctor's appointments on their own. And if they're not driving, I always ask, could you have gotten Uber to take you, or gotten a cab? Well, I have no idea how to do that. So then you know the person is going to be relying on other people. And in some cases, moving into assisted living, not memory care necessarily, is really a great thing for the person, because if they're living alone, they're isolated, and they're not getting enough social interaction or stimulation, it's actually a real blessing in disguise. A lot more activities, a lot more physical exercise too. Now, working is a complex activity that is a great diagnostic tool, actually. A few years ago, I evaluated an emergency room doctor who had been doing just fine until the hospital instituted a new computer system, and he was having to do a lot of new things for the charts, to put input information into the charts and that sort of thing, and he couldn't learn it. They're a very bright guy, and he couldn't learn it. They gave him extension after extension, and finally he consulted a neurologist who referred him to me, and sure enough, he had fairly significant short-term memory impairment, which is why he couldn't do the job. He retired because of this. Moving to a new neighborhood can be very revealing in terms of if someone has a problem. Now, this is a chart that was developed by Ron Peterson. It shows that this is a downward continuum, but there's overlap with normal aging and mild cognitive impairment. So there's a transitional phase in between each one of those levels. Now, mild cognitive impairment has subtypes. Amnestic MCI, which means there's a memory problem. It could be single domain type, where only memory is the issue. Multiple domain type is where there's memory and other cognitive domains impacted. It could be language or executive functioning. People with multiple domain type, that they're at a great risk of progressing to dementia. In fact, 70% of people with MCI will progress to dementia. It may take 8 or 9 years, but it's because they have Alzheimer's disease. That's what's causing the MCI. Now, not everyone with MCI has Alzheimer's disease, and some people with MCI can actually move back up into the normal range, depending on what the cause is. As I said, there's over 70 different causes. If someone is diagnosed with a thyroid condition and they didn't know they had, and it's treated, and it was causing memory problems, and now they don't have memory problems, they move back up into the normal range, or they have a vitamin deficiency or an infection of some kind. I moved back up into the normal range after the chemotherapy wore off, but you can stop a medication, and that can move you back up, or treat depression. Now, some people stay in the MCI range for the rest of their lives. Now, what would cause that? Perhaps a head injury. It's not so severe that they can't work or something, but they're definitely different. Or they had a couple of small strokes. They don't have dementia, but they have vascular cognitive impairment. There's actually a special term for people who have MCI caused by vascular disease. Now, the non-amnestic MCI, which can be single or multiple domain type, this means either language or executive functioning is impaired. Now, this oftentimes is the beginning of frontal temporal dementia. So these were the early signs that Bruce Willis was showing. Now, why are we seeing so many more people with dementia? It's because age is the #1 risk factor for developing dementia of the Alzheimer's type. Now, why am I showing Calvin Coolidge's son here? This young man, he was playing tennis with his older brother John at the White House in 1924. He got a blister on his right foot and it became infected and he died 1 week later. Now, this is because there were no antibiotics. Now, being the president's son, you would think you would have access to the best medical care in the country, and he did, but they couldn't save his life. Now it's a routine thing to treat this. So people didn't live long enough. Maybe if he had lived long enough, he would have developed Alzheimer's dementia, who knows? I'd like to share with you some facts about our aging population that explains why we're seeing so many more people with dementia. There's not many people that do exactly what I do in Orange County, but I am overwhelmed with referrals. And this is because so many more people are developing memory problems. In 1900, the average life expectancy for a person living in the United States was 47.3 years. Now it's about 30 years longer. And age is the #1 risk factor for developing dementia and MCI. And 97% of all cases of Alzheimer's dementia occur after the age of 65. So it was a rare thing when it was first discovered in 1906 by Dr. Alzheimer. The patient that had the disease was 55 at the time, and today she'd be classified as early onset. So this is why we're seeing so many more cases. Every day in this country, approximately 10,000 people turn 65. There are more people over the age of 65 than there are children younger than 5. There are approximately 54,000 Americans who are 100 years of age or older. We don't hear much about them. Laguna Woods is the oldest community in the United States. It has the highest average age. Now, it is the loss or death of brain cells or neurons that cause cognitive deficits and every single cognitive disorder. Doesn't matter what it is. And this is true for strokes, head injuries, brain tumors, severe brain infections, heavy alcohol use, severe and untreated sleep apnea, or a progressive disorder such as Alzheimer's disease, Lewy body disease, or frontal temporal lobar degeneration, frontal temporal dementia, previously called Pick's disease. You lose neurons, you're going to develop problems. So you got to protect your brain in every way you can. Now, someone can have MCI because they have sleep apnea and they don't use a CPAP machine. So all of a sudden they start using that, they're getting better sleep, and their cognitive functioning is better. They might actually move up into the normal range. So that's an example of how that could change in a positive direction. Now, someone who's drinking a lot of alcohol, well, that impacts sleep too. And it actually can make sleep apnea worse. So if someone is drinking heavily, and I've recently evaluated a couple of people who told me that they've been drinking heavily since they were 18 and now they're like 68 and they have memory problems. I strongly recommend that they stop drinking. They're in the MCI range and I can't promise them that they're going to move up into the average range because they've damaged so much of their brain by doing that. But they will sleep better and their brains are going to be healthier. I try to kind of alarm people that they're at risk if they keep doing some of the things they're doing. So, okay, now this is, I think it's worth describing kind of what's happening here. The frontal lobe, the green part there, is the frontal lobe, and that has to do with executive functioning. And that part of the brain doesn't start fully developing until you're 12. It doesn't finish developing until you're about 30, maybe 25 to 30. And you don't want anything to interfere with the full development of your frontal lobe, like alcohol or drug use. Because you probably know people that started using drugs and alcohol in their teenage years, and they still act like teenagers. I have a relative like that. He acts like he's 16. He has poor impulse control, poor judgment. He gets in fights. He just can't plan, can't organize. It's a mess. So if I had the time, I would go into high schools and tell kids how valuable the frontal lobes are and to protect that, because when that's fully functioning, now you're able to live on your own. Now you're able to succeed on a job. Now what happens with Alzheimer's disease, the frontal lobe gets damaged and it starts to get worse and worse. So the person regresses in terms of cognitive ability and personality and behavior. They begin to act more like a teenager and then more like a child. So what can happen with Alzheimer's disease is, now that's not so much, memory is managed in the hippocampus primarily. If that gets damaged, and it does get damaged by Alzheimer's disease, so the person develops problems with storing new information. They can still retrieve old information if they've given a cue, but they can't store new information very well. But the frontal lobe has to do with the ability to perform the complex activities of daily living. Planning, organizing, sequencing, complex problem solving. All those things that are necessary to live independently. Now the frontal lobe is also responsible for our brakes. It keeps us from punching someone who makes us upset. It also keeps us from saying hurtful things. So we have empathy when the frontal lobe is healthy. We can imagine how our words or behavior can negatively impact someone else. And you can see this in people who have dementia. They've lost that ability. They will say really cruel and hurtful things, and it's not them. And I have to kind of educate family members. Look, you shouldn't take this personally. This is the disease that's modified how your mom's brain is working. She never would have said these things before. The other thing is insight. You lose insight. You believe you could still live on your own when you can't. You don't see the connection between severe cognitive impairment and living independently. Okay, let's talk about dementia. I think everyone knows this is a serious neurocognitive disorder. It's a diagnosis, but it's also a condition, just like MCI. Something's causing this condition. There's over 70 different causes. Alzheimer's disease is the major cause. Alzheimer's disease is simply a disease. It's a disease that causes MCI first, then it causes dementia. That's the way we got to look at this. Virtually everybody I talk to that don't work in the field, they don't understand the difference between that. They say things like, well, my dad was diagnosed with dementia, but thank God he doesn't have Alzheimer's disease. Well, the first question should be, if someone's diagnosed with dementia, is what do you think's causing that? Is it vascular disease? Is it Alzheimer's disease? What is it? I just evaluated a gentleman. He has dementia. I saw him a year and a half ago. He had severe MCI, and he's progressed. Now what's interesting, he had an amyloid PET scan, and it was negative, which means he doesn't have Alzheimer's. Interesting that they would do that test, because his primary care physician wanted to know, is this Alzheimer's disease? Because he has severe vascular disease. He doesn't have Alzheimer's. However, he's continuing to decline because of the vascular disease. So it looks like Alzheimer's disease, and I could see how that might have been suspected. Pure vascular dementia is not that common. Okay, so I think most people know what the symptoms of dementia are: severe memory impairment except with frontal temporal dementia. There's no memory impairment, it's language or behavior. But there's all the other cognitive abilities start to be impacted: language, reasoning, visual spatial ability, certainly executive functioning. And there's personality changes that occur. There's two common associated features that may appear with MCI, but certainly do appear in many cases with dementia. The first is apathy. The person loses drive and motivation to do things. And in the literature, it says a preference to stay home. They rather stay home. And you can see this with people with MCI. And the family members think it's depression, but it's not depression, because I always do a depression scale and they're not depressed. But the family says, well, he doesn't want to do anything. And so that's a problem. And if someone is encouraged to walk every day, because we know that's good for them, they won't do it. Now, they'll do it if someone else says, let's go for a walk. But they don't have the ability to plan and execute. That's executive functioning. And follow through with a plan. The other common associated feature with dementia, and sometimes with MCI, is anxiety, an increase in anxiety. I suspect it has something to do with not feeling in control. It's like, what is going to happen today? And I'm not prepared for that. Certainly people with dementia have difficulty coping with new situations and change. They do not like change. If you go into any facility, everything is very regimented. Lunchtime is a certain time, bedtime is a certain time, bath time is a certain time, so that they can learn what the format is. They don't like surprises. So if you want to keep someone with dementia calm and not agitated, don't change things too much. Create a routine. Now, dementia is an umbrella term. As I said, there's over 70 causes. Some of the causes are reversible, but it's a very small percentage, probably less than 5%. Most causes for dementia are irreversible and progressive. Alzheimer's disease is the most common cause. But these are some of the reversible causes that the primary care physician always looks at first. If someone is complaining of a memory problem, so the doctors want to see, is there something that we could fix? And they do blood work, urinalysis. Is there some sort of an imbalance or vitamin deficiency or an infection? By the time I see someone, all these things have been ruled out. And the brain scan may or may not show very much, but it's designed to rule out things as well. Strokes, normal pressure hydrocephalus, a subdural hematoma, various things like that. Now, these are the four main types of dementia: Alzheimer's dementia, Lewy body dementia, frontal temporal dementia, and vascular dementia. You can see the percentages there. I think these percentages kind of change a little bit with more research. But there are other diseases that are quite rare, but they're on the list, like Creutzfeldt-Jakob disease, which is 1 in a million. It's very rare. And there's a new type of dementia called late dementia. I'm not going to go into that, but it only occurs in people 85 and older. So you have to live that long in order to develop that type of dementia. Now, approximately 94% of all dementias are actually caused by these four diseases: Alzheimer's disease, Lewy body disease, frontal temporal lobar degeneration, or vascular disease. Okay, I would like to share with you a little story that illustrates how memory works. This was a couple of years ago. A woman came up to me after I gave a talk, and she said, would you explain something that happened with my mother? Now, the woman she was 50 years old. She lives in San Jose, but comes down to visit her mother who lives in Laguna Woods. She lives in assisted living. She has mild to moderate Alzheimer's dementia. And the daughter comes down to take her shopping every weekend or whatever. And she said, this particular weekend I was going to take her to get her hair done. So I said, Mom, I want to take you to get your hair done. And the mom said, well, I want to go to the same salon I went to for 30 years. And the mom doesn't drive anymore. So the daughter said, well, what's the name of it? She says, well, I can't remember the name of it. The daughter said, well, what's the address? And the mom said, I don't remember the address, but I know how to get there because I drove there hundreds of times. And the daughter said, okay, we'll give it a shot. And according to the daughter, it took about 25 minutes to get there. But every time they would get to a light or a stop sign, the daughter asked the same question. Do we go straight? Do we turn left? Do we turn right? And according to the daughter, she didn't make a single mistake. However, every 3 or 4 minutes, the mom asked the same question. Where are we going? Now, I think that little story illustrates beautifully what family members see when someone has Alzheimer's disease. They can still remember old information because those memories were laid down when the hippocampi, you have one on each side, was healthy. And if I can use a little metaphor, it's more complicated than this, but the hippocampus, hippocampi, Greek for seahorse, it's like a little bridge. If I can use a metaphor, it's like a little bridge that information has to cross over to get stored in the cerebral cortex. New synapses, new memory traces are laid down, and with repetition, those memories are stronger. That's why they gave us flashcards as kids. And some things you'll likely never forget, even if you get middle stage Alzheimer's disease, like your date of birth, or 2 + 2 = 4. As the disease progresses, it destroys the storage sites, so you forget familiar things, your family members, even recognizing yourself in a mirror. So this is why I sometimes see in my office people that can tell me what they did in World War II, or where they went to the 2nd grade, and maybe they're 85 years old, who their best friends were. They can give you a lot of details about their early childhood, and I can get confirmation on that from talking to family members, but they can't tell me if they had breakfast. Or I can read them a story, and they say, I don't remember anything about what you just read me. That's because the hippocampus is so damaged by Alzheimer's disease, usually. So if you can think about that hippocampus as a bridge, the bridge is being destroyed, so they can't store new information. And I think that helps family members, because when they understand it that way, they realize, my mom, she can't help it. She can't help it. It's like she's becoming blind, and she can't help it that she can't see everything. And they become much more forgiving and compassionate. Now, what a lot of research is showing now, and this is through autopsies and various tests, that most types of dementia are mixed dementias, which means there's more than one disease causing or dementia causing disease. Like Alzheimer's disease, a lot of times these people also have vascular disease. And a lot of times people with Lewy body dementia also have Alzheimer's disease. And I can actually tell that on neuropsych testing, because with neuropsych testing, someone who has just Lewy body dementia, they have deficits in attention, executive functioning, and visual spatial, but their memories are essentially intact. But if they have Alzheimer's disease as well, they also have memory problems and language deficits. So I think that's just fascinating. And there's a frontal lobe variant of Alzheimer's disease that looks like frontal temporal dementia. So things can get confusing at times. Okay, these are some interesting questions. It's kind of a summary of what I've gone through. So is Alzheimer's disease the same as dementia? No. Alzheimer's disease is a disease that causes dementia. There are many causes for dementia. It so happens that Alzheimer's disease is the major cause for progressive dementia. Can someone have dementia and not have Alzheimer's disease? Of course. It could be vascular disease. It could be Lewy body dementia. Alzheimer's disease is one cause, but it happens to be the major cause of dementia. Can someone have Alzheimer's disease and not have dementia? Yes. They could have MCI. And you could actually confirm that it's Alzheimer's disease that's causing the MCI by a variety of tests that are available now. An amyloid PET scan, a tau PET scan, and analysis of cerebral spinal fluid. Is it possible for someone to have Alzheimer's disease and have no symptoms whatsoever? Yes, because Alzheimer's disease starts killing neurons in the entorhinal cortex of the brain for 10 to 20 years before you ever show symptoms. And that can actually be assessed for with some of the tests I just described. Okay, this is kind of a historical thing. That's Dr. Alzheimer on the left. And he was assigned this lady, Augusta Dieter, in 1903. She was admitted to a psychiatric hospital where he worked. He was a neurologist, a neuropathologist, and he also worked as a psychiatrist. And this woman presented. It's amazing that they have a photograph of this woman. But she died at 55. Now today she would be classified as early onset. And Dr. Alzheimer, he died at age 51. So he was right on par with the life expectancy of the time. And when he saw this woman, he felt like she was presenting a collection of symptoms he had not read about in the literature. He thought this was something very unusual. He became rather obsessed with this particular patient. He was very interested. Dr. Alzheimer's, he was a fascinating guy. And so he did an autopsy of her brain afterwards. And he found significant cerebral atrophy, which is a lot of shrinkage of her brain because of loss of neurons, right? And then he was fortunate enough to be able to look at samples of her brain under the microscope with a new staining technique that allowed him to see the amyloid plaque and the neurofibrillary tangles. And that's what he described in his first report about this. And so he's credited with being the first person to discover this disease. Okay, I think we're about finished, but I would like to leave with these recommendations. This is what is generally believed to be really good for the brain, to protect us, to buy us time. If we're destined to get a cognitive disorder, we need to delay the onset as much as we possibly can because there is no cure for Alzheimer's at this point. So engaging in exercise, simply walking 30 minutes a day is really good for you, for the brain. Cognitive activity, playing games, board games, taking classes, reading, writing is one of the best things you can do for your brain. Diet and nutrition are critical. Social engagement, getting good quality sleep. Sleep is now being recognized as something extremely critical to brain health and overall health, vascular health. Reduce or eliminate stress. That's very important. Exercise is a great way to do that. So, I think we're about finished for today, and hope you found this helpful. Thank you.